supply, kind of thing associated with it. So that's the worst case scenario, of course, but that can end up happening to your patient. Now, with our WBCs, these are all the things that are kind of strange. Sometimes patients, when you think about the leukemias especially, when you're looking at lab work, a lot of times people think that WBCs on leukemia patients are always decreased when you talk about leukemia. But leukemia is either high or low when you talk about the WBCs themselves. Okay? But just think about leukemia as an unregulated process that's happening in bone marrow, because that's where it originates from when you talk about a leukemia patient. So the bone marrow itself is being affected, and probably before, we're seeing this a lot more, that patients have what we call myelodysplastic syndrome before. You start to see some changes happening, but not quite to where you diagnose the patient as having leukemia, but that's what they used to call pre-leukemia, and it's called myelodysplastic syndrome. You start to see some changes that reflect that there's some type of malignancy happening in bone marrow. Okay. So this unregulated proliferation of cells, the bone marrow is then taken up by abnormal cells. Okay. So generally when you have a patient who has leukemia, all cell types have something going on. Okay, so that's how you always know that something is happening in bone marrow in the first place, is because cell types of all, WBCs, RBCs, and platelets have something going wrong with them. Okay. Now when you have patients who have leukemia, the white count is what they look at first, and the white count can be normal, the white count can be low, the white count can be high. It does all three different variations when you talk about leukemias in patients. What they do look at is tell you whether or not this is something that is a quick onset of symptoms, immature cells. Okay, so if you see a person was doing fine, all of a sudden starts presenting with symptoms like a week, 2 weeks, 3 weeks, that's the acute leukemia side. Chronic leukemia patients tend to just be living their life, doing their thing, maybe feeling tired. How long have you been feeling this way? Oh, 2 years. That's the kind of stuff they tell you when you finally end up doing something different with their lab work. Because yes, you can do a CBC and see they're a little anemic, but until you start looking at cells under a microscope, which pathology slides are for, peripheral smear kind of stuff, you don't end up seeing this. So it just looks like they have chronic anemias, and then they start seeing some changes in the cells themselves. And that's what kind of gives it away from you, give it away for your patient. But acute onset of symptoms, quick onset kind of thing, that's what you think about for your patient. You also think about acute leukemias are the ones that have temps when they come to see you, because they usually have an acute infection. That's what's going on when they come to see you. They tend to have bruising all over, because remember, all cell types are involved. So they have an infection because they can't get rid of things or fight it off. They have bruising all over. A lot of times you'll see when you pull their shirts up, they have bruising on the thorax, all over their body kind of thing. It's just madness. Okay. And then, of course, they tell you they feel tired all the time. That's the RBC portion of what's going on. I've been feeling tired. They may be pale. All of those things are going on because bone marrow has now been taken over by this malignant process. Okay. So acute onset of symptoms, immature cells, when they look at them under a microscope, tells you it's an acute leukemia. Insidious, slow onset, chronic leukemia patient. Cells are mature, meaning that they look like they're supposed to look, but the patient still has leukemia. So what the ones you're going to focus on, and there's a box in your book that kind of tells you, they're all together so you can compare them to each other about what you see in the patient. Because it really is, once you recognize this, it all becomes the same kind of thing. And the reason I kind of, when you think about these, because no matter what, when you do treatment for the patient, you're going to make them neutropenic, because chemotherapy does that. Okay, so even though it's a different process by which it happens, the end result is the same about how you have to take care of your patient. So I'm not going to ask you about the individual medications that go along with leukemia treatment, because that's different. Yeah, you got them for this one because you had to know those for cardiovascular stuff. That's the stuff you also see on your NCLEX exam. But they're not going to ask you about individual chemotherapy drugs. What they ask you about is the overall class of anti-neoplastic drugs. What do you do for a patient? Even though cancer is common, But they're going to ask you, well, heart disease is #1 killer. That's why you got to know stuff like that. But for this one, yes, there's 2 forms of cancer that are in the top 10, but they always ask you about it because the protocols change based on cell type. Okay, so that's one of the things that you end up seeing. Okay. So for lab work for this person, you're going to do a CBC, you're going to do a bone marrow aspiration and biopsy. Once we figure out what cell types they are, they look at what is favorable as far as treatment, meaning that does chemo work for this patient, or is this person a candidate for bone marrow transplant? Now think about that kind of stuff when you're talking about treating a patient. If they are a candidate where bone marrow transplant may be the thing of choice for the patient, you try not ever in your life to give the patient a transfusion. The reason being, if I give you a transfusion, I got to worry about those antibodies you create along with typing and crossing you for a bone marrow transplant. The more blood you give a patient, the less likely you are to get a bone marrow match. Okay, because people don't just go around getting transfusions, so they don't have antibodies to things. But the thing about it is when you're trying to do a transplant, you want as pure a specimen of patient and a person who's going to get the transplant to the patient. So those are things that even if this person is bad, you might see, you know, we try to hold off on doing any blood products until we decide whether or not we're going to do that for patients. If they're going to do chemo, because one of the other things they do, they're going to say, well, I need to get this under control. So the anti-neoplastic bandwagon comes here. Then it becomes, what do you do to protect the patient? So no matter what chemotherapy drug regimen a patient has, and you know they're never going to give just one drug when you're talking about chemo, because you got to attack this process at more than one place. Just like you did with TB drugs, just like you do with HIV drugs. Different drugs attack the cell cycle, so that if you're using different drugs together, they're killing it off at one time. Why the patient feels the sickest at the beginning is because I don't care about all this other stuff. I need to kill this, what you got. So remember I told you a few times in life you start drugs high. Chemo is one, because I need to get this process under control. So anything in the body that has a fast turnover is something that has a problem. That's why your hair falls out. That's why they have a lot of GI problems, because the cells along the GI tract turn over quickly. So that's part of the reason why you see the signs and symptoms you see in a patient. But what I'm going to do by doing that is kill off this whole proliferative process, so I'm going to make you even more immunosuppressed. Your WBCs didn't work in the first place, but now it's even worse. So that means this is big time precautions as far as you dealing with the patient, other people coming in and dealing with the patient. If you go to Moffitt, which I had to go to with, there's other places that I've been to where students are working on oncology units, but when you want to see what oncology is like, they have a thing where you wash your hands before you even go in the section where you're going, and then when you get to the bone marrow side, you have to do, there's another hand washing thing that they won't even let you in the door until they see you wash your hands at the sink. That's how serious it is, because patients who are so immunosuppressed that anything can make them sick. So they do that. You want to make sure that patient is safe. So any type of chemotherapy drug or neutropenic, patient goes on neutropenic precautions, and it means certain things they cannot have. Okay, no fresh flowers, even though people may love you and want to send you flowers in the hospital. Water can get bacteria, so therefore the patient can end up having an infection. They cannot eat fresh vegetables and fruits unless they've been washed, and anything with a peel has to have the peel off. So oranges, bananas, apples have to be peeled before they go in the room for the patient, because a peel is the source of bacteria for a patient who's immunosuppressed. As a nurse, you want to make sure, now remember, they don't have everything they're supposed to have now and can't fight off things. So they can have an overwhelming infection and the only thing they have is a fever. And you sit there and go like, where is it coming from? Patients who are oncology units, you have to actually investigate their whole body every day when they're getting chemo. That means you look at the groin, you look at the anus, you look inside the mouth. Because you need to see where the infection is coming from. Because if they have a wound, they might get some redness, but they don't have WBC, so they don't produce pus. That's the same thing that happens with a neutropenic patient. They can have an overwhelming infection. Most of the time you think, oh, the wound should have stuff coming out, but it really doesn't, because WBCs are what form pus. And if you don't have any, you can't make it. but the patient has an overwhelming infection. Because we normally think about overwhelming infection when stuff is draining all over the place. But these people don't have that. So it's all about safety. Once you figure out this is what they have, they're getting a chemotherapy regimen, then you have to keep them safe. So part of that, the WBC part of that, is making sure that you keep them safe from infection. So hand washing, neutropenic isolation, certain foods and things they can't have, no flowers in the room, kind of thing. When they walk out of their room, they put a mask on. People going into their room, put a mask on. Okay? If you have them, for the WBC side, they feel tired all the time. Okay, so you have to give them rest periods during care, because that's something they're going to have to deal with for a period of time. They may have poor tolerance to activity, so they may need supplemental O2. Those kind of things you're giving to the patient. Now, if their platelets are low, you got to worry about bleeding. So this means I'm going to restrict the amount of sticks I'm giving a patient. So sometimes you may see a patient that you draw all their lab doctors put in something, especially if they get chemo. They're going to get a Hickman or a Grosjean or a Mediport or something so they have access. Because chemotherapy drugs are very caustic to veins. They're considered vesicants. And when they infiltrate, they can cause you to lose skin on a hand. You can also lose circulation to the point where you need debridement and or amputation. So if they get some type of line put in, that's what you're going to be giving your medications through. They also draw their lab work through there. But minimally, you don't want to be sticking them all the time because they can ooze if their platelets are low. Also, don't give them a toothbrush to brush their teeth with. They get toothaches and those types of things because of gingival bleeding. You don't want that happening to the patient either. You're going to be looking at lab work every day. That's one of those things you kind of look at with this patient group. And then they're going to see whether or not some things are happening with them. Okay? So chemotherapy is the mainstay of treatment. So patients are going to get a lot of medication at first. So there's different phases that they go through when you talk about chemo. So induction is when they start. Then consolidation is that period of time where you may see, and they give several drugs when they're doing their chemotherapy. So consolidation is they're going to go back and see whether or not they have to give them the same drugs, or they may give them a different group of drugs that the patient is taking. Intensification is second, I'm thinking out loud. All right? Consolidation is the third one. Intensification is the name of that second one. So consolidation, whereas this is a person may actually end up taking a different medication or some of the other ones that they gave them before. And then their maintenance is going to be the last drug that they're going to be on for a period of time. Now, the goal of when you're giving chemotherapy for a patient is to get remission. Total remission means I have no activity of leukemia or cancer going on in bone marrow or anywhere else in the body. That's total remission. So that's what they're trying to achieve when they're giving you the chemo drugs. That's why they give it high, to kill off everything. I want this process to stop. So they're trying to get total remission. Partial remission means that you still have something going on somewhere. Okay, it's not that you got to remember all the pieces that go there. Just know that you still have something going on. So there's something either in bone marrow or somewhere in tissue where I'm seeing that I still have this cancer process going on. You never start patients on maintenance therapy until everything is gone, because you have to try to achieve remission first. Now, so all the thing that goes with them is all about safety once you do that. But look at the cell types in that box. Think of the general stuff you do for your patient because they have these issues going on. But they have a box there with all three of them together, or four of them, because the ALL one you don't have, because that's more, does happen in adults, but primarily happens in kids. So think about the cell type you see, acute, fast onset, because that's what you'll see in the questions. Patient has these symptoms and how fast they appear. Chronic onset is insidious, nobody really complaining, and they just put it off to other stuff. Kind of like we do in life in general kind of thing. So one of the other areas that, and I'll just talk about neutropenia since it goes more together with that one. Neutropenia can be relative or complete, meaning the patient doesn't have any WBCs at all. So their big issue is infection. or chance of or risk of infection. This is one of those times when you see a person has absolute neutropenia that a risk for diagnosis surpasses actuals, because anything they get can kill them. Whatever it is that they get will kill them, kind of thing. So their big thing is protection from infection. Good hand washing, observing for signs and symptoms of infection. Now we cause this in patients a lot, okay? Because if they had this cancer, we gave them a chemo drug, it causes neutropenia. If you have patients who take some of the other disease-modulating drugs, those are the Humiras, Remicade, all that kind of stuff we're using to control other things, also puts them at risk for neutropenia. So yeah, we see it in cancer, but you also see it for a lot of other things too. And that's the part of the commercial that gets real low, right? That's when you listen to the commercials about it on TV. They talk about it, but they don't want to say it really loud because people go like, I may not use that one after all. I always listen to all of it, but then I read it too. You know, as a chronic migraine person, I was like, man, I should try Botox. Then I see it can cause ALS. What? That's a trach thing, right? So I'm like, no, I can't deal with that possibility of sputum. That's got to go, kind of thing. So, but that's what you want to do, is protect them from infection. That's their major thing. With our lymphomas are things that, when we talk about leukemias and making that diagnosis, there were always something that fit outside the category, because that wasn't happening in bone marrow. Lymphomas happen in the lymph system, so they arise from the lymph system itself. And so what ends up happening most of the time is that you're going to see a person who has one lymph node or several of them that are going to be enlarged. The one thing to remember for your life as a nurse, not just for testing purposes, is that anytime you have lymph nodes that are enlarged and they're tender, painful, that's better. Even though the patient feels bad, or you may feel bad, when they're tender and painful, that usually means infection. So that's all. We just address whatever issue the person has. And just think about it yourself. If you're thinking about when you have a really bad cold, tonsillitis, I touched the inside of my mouth, thought I was going to die last week. That's why I ended up getting swabbed on Thursday. I was like, I was going to pass out. And I ended up with a trach. You know, it's like in my head, that's all I'm thinking about. All right? So if you have patients who have one of these disorders, if you have tenderness and pain associated with it, which you'll get if you do your kids when they have ear infections, touching them on the side of their face, say, oh no, mommy, daddy. They don't like that because it's tender. So infection usually means warmth and tenderness. You don't like it, but that's better. Anything that is hard, you can't move it, those are things that usually mean malignancy. All the time, 100% no, but the vast majority, probably 99.95% of the time, those things are malignant. So if it's painless, you can't move it, it's just kind of stuck there, it's hard, those are things we always want to evaluate. You want to evaluate anyway, but tenderness always kind of tells us infection going on. Anything that's hard, I can't see anything in it, or what we call cold nodules, we always worry about whether or not it's malignancy in a patient. So those will be things we would look for. Okay. Now one of the things that they can be anywhere. You talk about lymph node enlargements because they go all over the body. Most of the time we think about them in the neck and behind the ear, that kind of thing, but they actually go throughout your body. And when you're looking at the textbook, you're going to see that when they're staging the person who has Hodgkin's, they're talking about lymph nodes in the chest, in the abdomen, pelvis. You'll see pictures of it when they talk about stage 1, 2, and all that kind of thing. But the thing about it is when a person comes to see you, you ain't thinking about no stage, you're just thinking about where they are. Okay? If there are things under the armpit kind of stuff, you know, because those are usually the tender ones, that's good. But if they're hard, you still think malignancy. The ones that you worry about is when a patient has lymph nodes enlarged above the clavicle. They are called the sentinel nodes, and those are the nodes that if something happens with you, that's a lot of times where you'll see it happen first. Not that the other ones don't have things happen to them, but when you see things happening above the clavicle, you see a hard lump there, you see it because a lot that they get enlarged, and patients that you're doing this and they're, everything okay? Yeah, they don't feel anything, you worry. If there's tenderness there, it could be something draining out of the head. So that's better. Not nice, but better. Okay? But the sentinel nodes actually sit above the clavicle. So when you see things happen there, it's kind of ominous. We'll say, hey, we need to send you for a biopsy. What they're going to do is actually biopsy the patient for sure, okay? Because one of the things that you have to do is figure out whether it is that or not. They can also do some mapping, so they can actually do a lymph test where they actually give you a contrast dye that is injected into your lymph system. Now what's crazy about that is that most of the time you think about patients going for a procedure where you inject something in so you can see it, it's right then, it's immediately. You know, you're going to give this person contrast dye in the IV, and then you're going to see what's going on within minutes. When you're talking about a lymph mapping, it actually takes about 4 days. The lymph system, although it has fluid running through it all the time, takes a long time to make transit throughout the body. So it takes about 4 days. So they're going to give you the contrast, bring you back in to actually see if everything lights up or not. You want things to light up. When things are cold, they look dark on an x-ray. So it really does look like a little black dot somewhere. When you see a lot of those, that's the ominous kind of thing. But it takes about 4 days for that contrast to run through your lymph system. So a patient may start off in the hospital and go home. We bring them back to do that. But biopsy will be done. So they'll be looking for some things on biopsy report. So Reed Sternberg cells, some dudes, because it's two of them. Reed Sternberg is a big mononucleated cell that you see in patients who have Hodgkin's lymphoma. Now, like I said, if you had to have one, Hodgkin's has the better cure rate. It really does, especially if it's stage 1. Because yes, you have disease, but they find it in the first stages, so that means there's a few lymph nodes involved. Those are patients that have the highest cure rate. Even stage 2 has a pretty good cure rate. Okay. But once you get into 3 or 4, they have longer. But always remember, when a patient is asking you that question, or that question may come back to you, all you say is an open-ended question back to them. What do you understand about your disease? You don't ever tell them there's a cure. You don't ever tell them that if you survive 5 years, because you know somebody can die on day 5.1 kind of thing. So you never tell people those types of things. It's always an open-ended question. What do you understand about your disease process? What are you talking about with your treatment? You're going to feel like heck kind of thing. You know, because that's usually what happens. Chemotherapy is one of those weird things. You have some people do chemo and never have a problem. And then other people are sick the whole entire time that they're going through. That they start to say, why am I doing this? Kind of thing. I will tell you, with no matter what type of issue that you have, as far as when you're using chemotherapy, is that you will have some people that it's really is that piece of time they have to try to make a decision about what they want to do going forward. Because with a leukemia patient, it may give me time to, yes, get the disease under control, but it also may give me time to get bone marrow matched so I can have that treatment done. So I can achieve cure, because that's what they're trying to do in a patient. Whenever you're talking about doing a bone marrow on a patient for whatever reason, I forgot to tell you that when we were talking about chemo, is that chemo has to clear your system before you can do a bone marrow. Otherwise, the chemo will kill off the bone marrow that was transplanted in the patient. So sometimes, even though your patient gets chemo now, they're in the hospital for weeks at a time because all the medication has to clear out of their system before they can do a bone marrow transplant on a patient. But Hodgkin's disease, once they find out and they do their biopsy, they're going to say if it's radiosensitive or chemosensitive. Because sometimes you treat these patients with radiation, sometimes you treat them with chemo, or sometimes you treat them with both. And I will tell you that part of what that biopsy does is tell you that if it's more radiosensitive, they start with radiation first. If it's more chemosensitive, then they're going to start with chemotherapy first. Because you're going to do what works best. Because that can help shrink tumors, all that kind of stuff that's going on if it's radiosensitive in the patient. Now what they'll do is continue to monitor the patient, same kind of things we did for all, once you get into all these diseases, you're doing the same kind of monitoring. If they had chemo, same kind of things. Radiation, make sure they don't wash off the markers on their skin, because that's sometimes what patients want to do. These markers are there, what does this need to go away? No, you need to leave them there because that tells us where we need to put the radiation when you come down for treatment. It also is going to be a place where you can have skin breakdown and put you at risk for infection. So make sure the patient understands to wash and dry with gentle soap and water. So you can use like ivory, dial, something like that. You can't do the Victoria's Secrets kind of things. Okay, they have to kind of stay away from those. No lotion, creams, or powders on the area that's irradiated. It just needs to be pat dry. and that's it. You monitor it because they can have skin breakdown. The skin can denude, it can get very nasty. They can also get blisters, all that kind of stuff can happen. So you want to try to avoid those things happening to your patient. If you have anybody who is getting radiation around the pelvic area, because remember, if you look at the picture, you're going to see some things that talk about above the diaphragm. Then you're going to see seeding in the abdomen, seeding down into the pelvic area. If the patient is getting radiation there, you got to talk to people, especially younger ones, about reproduction. Because if I do radiation in this area, I may cause sterility. So if you have a young woman who is getting radiation in her pelvic area, she may not be able to have her own children. And a guy may not be able to have his own children because his sperm is affected. So if you're going to irradiate those areas, family planning is something you have to talk to patients about. Because this is the time we can harvest eggs and harvest sperm in case they want to have their own children later. It's not that it's going to get rid of the pieces that are there, the parts of the reproductive system you need. It's just that you can cause sterility. So then that's why you want to talk to the patients about it. Now, non-Hodgkin's lymphoma is a little different from the presenting symptoms that you see for, I mean, they still have the same thing. It's diagnosed the same way, so diagnostic testing wise. They usually also have, a lot of patients who present with non-Hodgkin's also tend to have respiratory complaints when they're diagnosed.